my screen?
Yeah.
Okay. Is it clear?
Yeah.
Okay.
Yeah.
Good evening, everybody. It's a great honor and pleasure to be the last speaker on this fruitful day after my sincere colleagues, friends, and professors. So hopefully this will be less complicated, more basic about one of the common scenarios that all of us faced from day to day, which is femoral shaft nonunion on intramedullary nail. This will be exclusive for aseptic nonunion, so we are not going into any sort of infection. I'm Ahmed Elsheikh. I'm a lecturer of orthopedic surgery at Benha University. So what are we going to shed light on this hopefully 20-minute talk will be the analysis of non-union, overview on 3 major options to treat non-union over a nail, which is dynamization, exchange nailing, augmented plate, and then where we are in terms of literature and the conclusion. So these are the 3 main things that we can do to treat non-union over a nail. But let's get back a few steps backward and have some overview of the definitions. What's the difference between union and consolidation, and what is delayed union and what is non-union? All these are basic concepts, but I would like just to spot the light to make sure that everyone on the same page. So union means that it's incomplete repair. The fracture line is slightly visible in X-ray. We can get cortices that are in continuity in, as we agree, 3 cortices out of 3. But at this time point, the fracture is not 100% secure, and there might be slight tenderness or mild tenderness over the fracture site. But usually this is the point that we are aiming to allow the patient to put more weight on it. But consolidation, this is a later stage where the repair is complete, no tenderness, and the fracture is so solid. And it's logically that consolidation is a later stage than union. So what is delayed union? What is non-union? Delayed union means that there is no radiological signs of progression of healing after 4 to 6 months after the injury. And non-union, which means that you have nothing on the X-ray after 9 to 12 months. So we can say that before 6 months, it will be very difficult to assume that this fracture is not going to delayed or non-union. These are the most commonly accepted definition of the union and non-union. Today we have previous talks. We have already came through how to analyze the union, and all of what professors mentioned are all accepted ways to describe the union. I'll try to offer few more steps how to do this, and you can adapt any of these techniques. All ends in the same point. What I like is the definition or the approach that is written by Nagam in Apple's Handbook of Orthopedics, which is the CAS approach: contact, alignment, stability, stimulation. So simply, when you look at a fracture that doesn't unite, so ask yourself these 4 questions. What about the contact? Is there bony contact or not? Is there a gap or not? Number 2, alignment, which Mr. Khalil has highlighted. The alignment is very important in having union. So if there is a deformity across the fracture site, this would end up in a union. So alignment, is it properly aligned or not? Number 3, stability, and this is the mechanical aspect, mechanical environment, strain level. Is it too much, too little? So stability. And number 4, stimulation, which means are we having the normal stimulation of the fracture union, which equate to weight bearing? So is the patient is weight bearing or not? This is one of the things. All these things are mostly a mechanical analysis of the union. Do not forget the biological, patient-related reasons. Infection, which is not part of our talk, this specific talk, but infection is something that you have to figure out either by markers in the blood or either by some other radiological imaging like MRI, PET-CT, SPECT-CT, or whatever. Pulse of tissue and blood supply. definitely there is difference between nonunion in the femur with a good soft tissue envelope and nonunion in a distal tibia, where the distal tibia has a very poor blood supply, or a nonunion with an area with a soft tissue loss. So the poor soft tissue is something to take into consideration. And also other biological factors like smoking, which is known to stop union or make it at least takes double the time, or having some cytotoxic drugs, having anti-inflammatory medications, or drug abuse. So apart from the other reasons, let's focus on analyze the X-ray with the CAS approach. So for example, this gentleman, after 1 year of having intramedullary nailing for a closed fracture femur, and he has this picture. So let's have a look. Contact, is there a contact? Definitely not, there is a gap. Is it aligned? It is aligned, that's fine. Is it stable? We can doubt. We see here some of the medulla still around the nail, so the nail is not 100% securing it. Stimulation, he's not putting any weight because they are afraid of having some bending of the screws. Of course, you can suspect here some infection because of this reaction and this loosening. This has been excluded by doing a PET-CT, but let's practice the CAS approach in these X-rays. This is the second X-ray to practice the same approach. So is there a contact? Yes, this gap would not count as a gap. You can say what is the amount of gap that you are looking for. Literature saying something about microns or so, but let's make it simple and let's make it in millimeter or 2 millimeter would be acceptable gap. But more than this would be just an obvious gap on the X-ray and you wouldn't accept it. So in this one, there is a good contact in both planes. So number two, alignment. Is it aligned? Yes, you can see that in the lateral view, there is some mild angulation, but again, this wouldn't be the major problem. Number three, is it stable? Definitely not. This is the problem with this one. You can see clearly that the medulla is wide around the nail here, so definitely this fracture is not stable. Is it stimulated? No, it's not stimulated again because the previous doctors doesn't allow the patient to weight bear, afraid of having some bending on the locking screws or failure of the metal. So let's go to the options. The first option is dynamization. Dynamization has been present all the time, and I totally agree with Prof. Sharma about what he said about dynamization. Dynamization is a bit overrated, and it's indicated in many cases, which in reality, it should be contraindicated. My message here that take care with dynamization. So in this a bit old study that has been done about 15 years ago, 980 closed femoral fractures treated with a static interlocking nail, and then 75 of these patients have dynamized, 104 was left static. Is it necessary? Surprisingly, no. Dynamization has been done at a mean of about 90 days, which 3 months time, and over 20 years of experience with these 180 nails, the time to union was shorter in the static group. So this is one piece of evidence that dynamization is not a good thing to do. But this is one report. Why don't we go to a more robust evidence? Let's look at this systematic review. This systematic review is a very recent one from 2018, and it compared the dynamization versus exchange nailing. They included 31 articles published between 1973 and 2015. They included the non-united and the delayed union also. They included both, and they included all sides of the femur, which is a very critical thing when you are looking into an union over an intramedullary nail. What have we got? So we have got that dynamization has the lowest percent of union in comparison to exchange nailing. There was no specific difference between nail with static locking or dynamic locking. This is one thing that would argue that it would make a difference, but it doesn't make a difference. So the conclusion here, the dynamization has the lowest probability of union. There was no significant difference in the average time to union, but if united. So it can lead to union, but in a lower percentage, 66% in comparison to 84% with exchange nailing. Three more things that were very crucial in this analysis: that tobacco use has negative impact. This is already known. Infra or supraethmal fracture has a negative impact. And this is again very important. So if you have a fracture which is supraethmal, infraethmal, please don't do dynamization, because the isthmus is the most narrow area, and this is mostly the area that is holding the nail. So you can do dynamization if the fracture is there. This might be acceptable. But if you have a fracture which is distal to the isthmus, like the X-ray that I've shown, why would you do a dynamization? This would add more instability. This would definitely lead to nonunion. And of course, infection has negative impact, and this is not part of our analysis. So from this systematic review, it's evidence that dynamization has less probability of nonunion. Less probability of union, so it is not advised to do it. And this is more contraindicated with infra or supraesmal fractures. So exchange nailing showed higher union rate with comparable healing time in treating nonunion. But the two procedures showed no significant difference in terms of delayed union. So in this analysis, it has some distinction between treating delayed union or non-union. So if you have a delayed union, it doesn't make a difference. You can do exchange nailing or dynamization, and you might win. But if you have non-union, so definitely don't do dynamization. So this is the message from the systematic review. Dynamization can be offered as a treatment for delayed union. It might work, but with established non-union, it's strongly advisable not to do it. This is the first message. About the other option, which is either exchange nailing or plating, because plating has emerged over years as a supplemental treatment over the nail to achieve union. So this retrospective cohort study included patients in 2004 till 2015. 140 patients had revision for aseptic non-union, and they compared the results between the augmented plate versus exchange nailing. There were 70 patients had exchange nailing and 26 patients augmented plate. What are the results? So both were effective, but augmented plate achieved higher union rate, shorter operative time, and shorter time to union. So again, it's a very critical outcome, because exchange nailing has been seen by many colleagues as the first choice. Let's do exchange nailing. It has been offered as an easier treatment, going through the same incision, don't open the fracture site, and it should work. It is working, but it's not the standard, and it's not the only option. Another option, which is opening the fracture site, refreshing the fracture area, putting a graft, adding a plate over the nail, would offer better chance to union, shorter operative time, and less time to union. Let's have a closer look on these options. Again, this is a review. 2019 included 3 studies, 232 patients, compared also between the exchange nailing versus augmented plate, delayed union or non-union. What were the results? Again, augmented plating was superior, shorter operative time, less intraoperative blood loss, and this is very maybe surprising, because people look at the intramedullary surgery as a surgery that doesn't bleed. No, there is reaming. There is significant blood loss from reaming. So intraoperative blood loss would be less if you just open the fracture site and put a plate. And this is a very critical thing to consider. Shorter time to union and lower non-union rate. There were no significant difference in terms of infection, which some people might say that if you open the fracture site, you might jeopardize the infection and have some infection, but it's not a big problem. They are both similar. This is the last systematic review, and again, it's published 2018, and it compared between exchange nailing, augmented plating, for specifically femoral diaphyseal nonunion, and they were not able to do, they had a systematic review of this good amount of papers, about 30 plus papers. What did they have? The union rate with the plate was 99.8% compared to 74%. So we can see again that putting a plate over the nail secure a better chance to unite. Time to union was slightly shorter with plate than excision nailing, but this was not statistically significant. So it was the more important that you will achieve union. Doesn't matter the time, even though the time with the plate is much shorter. So it's another positive thing in having a plate over the nail. Complication rate, again, it's far less in the augmented plate. It's 4% in the augmented plate versus 20%. But let's just make it clear that this 20% include failure to union, which we already know. So this amount of complications, it's just augmented by the reality that failure to union is one of these complications. So from this systematic review, augmented plate, union rate much higher and slightly shorter. What about putting the bone graft in this? So bone graft has been used with 10% only exchange nailing. So again, this is one of the questions that you do exchange nailing only and you count on the reaming will go into the nonunion site. Again, it doesn't make that sense, because when you open the fracture site, it's not empty. There is fibrous tissue in there, and the reamings would not push this fibrous tissue away. So there is something in there. But when you open it, take this fibrous tissue out, put the graft, you achieve a bony contact, filling the gap, and gives osteoinductive, inductive and conductive properties of the graft. But of course, with the augmented plate, in 80% we use graft, which because you're already in there, so don't lose the chance to do the bone graft. Surprisingly, with the exchange nailing group, people who had the graft had a better chance of union, which put some light over the graft effect on the fracture site. So we can see that the graft has some positive effect, but again, this is not overlooked by the mechanical properties of having the plate. Last bit of the evidence, what does the plate achieve? So this is the point. This has been proved by this nice biomechanical study in 10 years ago. They compared the mechanical rigidity between the plate over the nail and the nail alone in the cadaveric fracture. And they had studied 13 cadaveric fractures, did simple transverse fracture and the midshaft, and tested one with the nail only and one with the plate over the nail. And here is the answer. There was 2.6-fold increase in the bending stiffness and 3.3-fold increase in the torsional stiffness with the plate augmentation. So this is the key. The plate abolish the rotational instability of the nail, which is there. Even if the nail is statically locked, there is some rotational instability, and the plate takes this away. So coming back to this case, which we have presented in the beginning, and this one, we said that there is a contact, there is a good alignment, but there is no stability. We can see that the medulla is wide around the nail here, and there is no stimulation. Surprisingly, this gentleman, when you see here, you can see the distal part of the femur, and it's still locked. You can see it rotates. So this is the biomechanical answer of the rule of the plate. So the plate here in this gentleman, this gap is not that big. We just stopped it with some iliac bone graft, and then adding a plate. The plate might be challenging to get bicortical birches. You can go in the front of the nail, behind the nail, or you can just do unicortical. That's fine with locked plate. Two or three screws on each side, put the graft, and that's it. When the plate is there, it changes the biomechanical environment. the strain level changes, and it turns into bone. There might be argument about shall you put a graft or not? This is a good question to have an answer. I don't have a really answer. There are some theory that the tissues in there will respond according to the strain level. This is called unified theory of union, and this theory might have an answer of this, that if we just put a plate without debriding the graft site, the nonunion site, or without doing judea decortication, would it unite? I don't know the answer, but this is just one of the questions. But as all these reports, they did classic debridement at the nonunion site and putting a graft, maybe some judea decortication on the plate. So to conclude this lecture, so it's very important to understand the causes and the many variables. It's in this day we have put many spotlights over the different things that you should have in your mind to ask about, to know the personality of the nonunion, why this is happening, and why me, as we asked in the beginning of the day. Dynamization, very limited rule, might be used only for delayed union, but not for non-union. Take care of shortening. You might lose a centimeter or so if there is a gap already. So just take care of this. And of course, don't do it in an ethmal fracture. So we say that dynamization, as Professor highlighted, it's a very common decision, but it's not a sound decision in many cases. Exchange nailing, the most popular opinion, but again, it's not guaranteed. Less probability of union. Also, again, you might still have the same problem with the stability. If you exchange nailing for an infra-ethmal fracture, nothing will happen. Even if you could put a bigger nail, the bigger nail will be jammed in the isthmus, but again, it will still allow some rotation in the infra-ethmal. And if you need bone graft, so you open the fracture site, so what's the point? You can just put a plate there. Augmented plate, this would be my personal preferred treatment. And from the literature, it's also supported that it's better chance to union, might be a little bit shorter time to union, it's better stability. Using a bone graft or not, at the moment, most of the times, if you are already in there, just put the graft, you will have done everything for this. I hope that I covered this part, and it's very common scenario for all my colleagues that it's every day, what about the union around the nail, and hopefully you find this useful.
Thank you so much دكتور أحمد. ده كان ختام المسك للبرزنتيشنز الأكثر من رائعة اللي سمعناها النهاردة.
The second set of question is for Professor Ahmed Elsheikh about the exchange of the nailing of the femur non-union. Would you please highlight why dynamization doesn't work? Because what we need in delayed union just a compression, and we can achieve it with dynamization. Why it doesn't work?
Because you might have compression, but you lose rotation. So this in many cases led to non-union. It might work, but again with maybe ethmal fractures that you got a good hold around the nail, so it might achieve the compression, and maybe the rotation doesn't change that much. And in delayed union, not in established non-union, which makes biology is not that fresh. So it might work in this scenario, but in other cases where there's a wide medulla, infra-ethmal, supra-ethmal, you just add more instability. And I showed you this video. It's very quite interesting video because the nail is locked and it's moving. So this is the problem with the change, that you might not gain anything with change nailing. But still, it works. But we are talking about the probability of union.
Okay, brilliant. Thank you very much.
Ahmed, I have a question for Ahmed Elsheikh for the plating over the nail. You have a non-unions patient come to your clinic with a non-unions after maybe open femur fracture. And what's your change the technique for plating? You just put the plate in fixation in situ, you have to do compression around the nail. What's your plate technique different from the regular techniques? Because most of the time I do exchange nailing, I put a bigger nail, but instead of using the reamer, we have the area, which graft the femur from the femur.
Okay.
And I put bigger nail, and lock the nail, and then there's the new nails has a compression system. You can compress with the new nail system from the top. You lock distal and post the dynamic hole proximal, and there's a screwdriver. You can compress the nail around the fracture site to reduce the gap and improve the contact at the fracture site or non-union site. And then put the bone graft, decorticate, and do your non-union work.
So you open the fracture site?
Just for decortication or,
okay.
yes, like shingling the techniques. And then I put a bone graft. So I need to ask you about the infections. Do you send the, if you do anything for rule out infection? Number two, what is your technique for plating? You compress, eccentric drilling, what you do exactly to reduce the gap at the fracture site? You need compression at the fracture site or non-union site.
In terms of infection, I will do PET-CT. I've done this a couple of times with patients and see if, unfortunately, the non-union itself as a biological activity might have some uptake, but it won't be that high. So in terms of PET-CT, we used to have 1 is a normal. If you got about 2, this is a bit acceptable within the normal activity of non-union. But if you got 4, 5, 6, this is definitely uptake that comes in line with infection. This is just one piece of the evidence. There might be other blood markers, CBC, ESR, and stuff like this.
You don't know the organism. You need culture, the reamed material to know what organism to give antibiotics, especially for slow-growing organism like staph AB or B. acne or other very slowly grow organism. I mean, PET scan is not, I don't think, is good, but it's not enough to know the organism.
Yeah, I think in terms of putting a plate, this might be more toward the aseptic non-unions. So for the people that we don't originally suspect there, because why would I take the risk in a patient who is at risk of having infection opening and adding more metal inside? So I would be more conservative in this term. So I would say that all these reports direct toward aseptic non-union techniques. The other thing about compression, it's not my technique. This all it's like a critical appraisal. What I've done a few cases, and I didn't do something specific to having compression. I just put a plate in situ without doing. I didn't find in any of these reports, systematic reviews, that there is description of certain way to do a compression. It might be good to have compression, but if you fill the gap already with the graft and the nail already inside, the plate will just increase the stiffness in rotation, especially. Then you change the biological and mechanical environment. So just another viable option. It might be achieving the compression with a nail, like the technique that you said might end up with the same result, especially with adding the graft and at the fracture side. This is a very positive thing.
Yeah, and also there's some people use the external fixer around the nail. So put the 2 external like monoplanar external fixer around the nail and then try compress, because they need compression around the fracture side. Very, very important to achieve compression. You achieve it with the nail, you achieve it with the plate, you achieve it with X-Fix. There's different ways, and rule out infection is very important to make sure there's no infection.
Yeah. Just highlight one thing from all the details that you described. Only exchange nailing, normal nailing, without doing anything, without achieving proper compression or adding graft, might not work. So this is the problem that people look at simply at X-ray with nail. This exchange nail, do standard exchange nailing without having the other bits of the picture, either achieve compression by the nail itself or by external fixator, putting some graft. All these things increase the chance of getting the union at the end.
And also the medical management of non-unions, do thyroid, parathyroid, kidney function,
smoking,
all these factors are very important. Vitamin D, very important. Okay, so I have to make sure there is no other medical factors that
absolutely
help with the non-union. Okay.
Mr. Sheikh, I have a question about the construct of your plate. Would you put it as a non-locking, locking, uni-cortical or bicortical?
No, it should be locking, because you will struggle to get bicortical grip on both sides. Definitely, it will be very, very difficult. You might get intracortical in the either on the front or the back of the nail. This again won't be that stable, so you should go for locked, because if you don't go through over the nail, so you just be unicortical on one side. And this has been described, and there was no distinct differentiation between the both. So I go for locked.
But Dr. Ahmed, sorry. If you use a locked plate, you cannot direct your screw.
Exactly. I will put one non-locked with that I can manipulate up and down, and then the other one or two I will put locked to have the locked effect as internal external fixator. You're absolutely right. This is one of the things that have to work around.
There is actually the variable angle option in some of the lock plating, which will enable you to manipulate the direction.
Yeah, this is another option also.
The other thing also about the infection non-union, I like the discussion. Personally, I take samples for any revision case, whether it's an arthroplasty, non-union, or any of these, because usually having low-grade infection like P. acne, like what Prof. Thabit have mentioned, I think this is always, and interestingly, some of these patients, especially the non-united patients, you find the micro coming back with bugs, although you didn't doubt any of the bugs while doing the procedure. So that's always one of the top differentials. Although usually it is mechanical, but I think also infected non-union is a underestimated problem we face in orthopedics.
You have to ask for stool cultures. Take 2 weeks to culture this organism. Like
I think 5.
It's not an
for aerobics, 5 for the fungi.
Yes, for every. But no, in pediatrics, I wouldn't do that in pediatrics. But I think because that's actually what we've learned from Bavrizia and all that work in in infected arthroplasty, and so we've also looked at some of the stuff. But if you can take the more, the merrier. That's what I say. So the problem would be the contaminated samples you might do if you take more. But I think non-infection should be excluded. But if the patient is asymptomatic and they achieve union, usually it might be a contamination. But I think excluding infection is crucial here. And we're lucky because with also plating, now we have different options and we have technology on our side, so we can use variable angle whenever we want while fixing these fractures. It was a very interesting talk by all of you. It was a pleasure listening to all these lectures.
There is a question from Dr. Very much. The question is for Prof. Ahmed Elsheikh. About the plating over the nail. Would you put a plate over static nail, or you'll dynamize it or remove the screws from the nail?
I think from what I've presented, from all the evidence that I have, I think I admit that dynamization is not a good option at all. So I will just leave the nail static as it is. I need more stability. So I jeopardize my stability by doing the dynamization. This is against the first part of the talk. The dynamization in many cases is not a good thing. It might work in few selected cases, but going for augmented plate you don't have to do dynamization. You just add the plate over the static nail. You add more stability. You don't have to do this.
Brilliant. Thank you very much. I don't have any more questions. Thank you very much all.